All right, let's see here. So, got this, got that. All right, so just to refresh your memory, it's going to be the exact same format as you guys are used to. So 100 questions. It's going to be with a Scantron, so make sure you bring a number 2 pencil, right? Or if you don't have one, you got to borrow one up here, but they don't always have erasers, so don't forget that. Of those 100 questions, the vast majority are multiple choice. I want to say like 97 or so, I think, are multiple choice. And they're going to be usually, 5 choices that you have to go through. Almost all of them are just pick one answer. If there's ever one that says pick, 2 or more, pick all that are correct, it'll definitely say that, but I think the vast majority are just pick one answer. And then the remaining handful of questions are just going to be true, false, right? So definitely a lot of multiple choice, so get yourself psyched for that. In terms of the question breakdown per chapter, it's pretty much evenly split. So it's around 33, 34 questions per each chapter. Okay, so it's an even split. All right, any questions about the form? Make sure you show up on time so you get the full amount of time, blah, 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 all that stuff. Any questions about any of that stuff? All right, so let's go with the blood chapter first, chapter 19. What were some of the functions of the blood? Transporting materials around the body, like oxygen, glucose, etc. Temperature regulation, what else?
pH regulation.
pH regulation, protection from blood loss. What's that general term that means like holding the blood steady?
Clotting.
Hemostasis. Clotting's a part of it, but I was
Yeah.
looking for hemostasis, yeah. And then also protection against what else? What do the white blood cells do? Yeah, like infections, right? Protecting against infections. So those are all functions. How much, what's a good sort of average value for like your total blood volume? 5 liters, good. What's a typical temperature for your blood? Well, that's the pH, 7.35 to 7.45, and I was going to ask that, so you're just a little bit ahead of me. That's okay. What's the temperature though?
100.4.
Like 100.4, right? A little bit warmer than like what your core is usually thought of. Now, going back to A&P1, not that anyone wants to go back, but if you had to go back, we talked about the 4 general tissue types. Which of the 4 general tissue types is blood classified as?
Connective.
Connective tissue. So with a connective tissue, you can either talk about the cells or you can talk about the space outside of the cells, the extracellular matrix. What's the name we give to the extracellular matrix of blood?
Plasma.
Plasma, and it's a liquid extracellular matrix. Plasma is mostly just made up of what? Water. 91.5% water, okay? We'll talk more about the plasma here in a moment. And then the other part, the cell part, is called the what? Formed elements. Why don't they just call them the cells?
Why? Science.
Well, because platelets are not actually whole cells, right? So you got red blood cells, you got white blood cells, you got platelets, and they make up the quote-unquote formed elements, right? All right, back to the plasma. Mostly water, but then you also have some proteins that are there. What's the most common type of protein in your plasma? Albumin, good. What's the second most common type? Globulins. Specifically, there was a really important type of globulin. What's the type of globulins that fight off infections? Gamma globulins, good. Which are better known as what? What do we usually call them?
Antibodies.
Antibodies, right? Gamma globulins are the same thing as antibodies, right? And then what's the third most common? Fibrinogen, right? And what's fibrinogen involved in? Yeah, blood clotting, good. Talking of the formed elements, which of the 3 formed elements are the most common? Red blood cells, right? How many red blood cells do you have in a microliter of blood?
Between 4 and 5.
Yeah, somewhere, that's right. Somewhere around, hovering around like 5 million per microliter. And then you have, what's the next most common?
White cells.
Well, the next most common would actually be platelets, right? They're about 150 to 400,000 per microliter, and then white blood cells, which are like 5,000 to 10,000. So let's talk about the red blood cells first. What's the name we give to the percentage of your blood that's made up of red blood cells? Yeah, the hematocrit. That's a very, very, very common blood test. You're definitely going to see it a lot in your clinical careers. All right. What's the name given to the process of forming blood? Yeah, hematopoiesis or hemopoiesis. That means to form blood. And where in your body are blood cells formed?
Bone marrow.
Yeah, what kind of bone marrow? Red bone marrow. What kind of cells are formed in the red bone marrow? All of them. Good. And they come basically from like this great-great-grandmother cell called like the myeloid, the pluripotent stem cell. Sorry, the pluripotent stem cell. From there you have two pathways you can follow. Most blood cells are going to follow what pathway? The myeloid pathway or the myeloid line. Unless you're going to become what? Yeah, unless you're going to become a lymphocyte, then you follow the lymphoid line, right? Okay? So most are going to follow the myeloid line. Unless you're a lymphocyte, then you follow the lymphoid line. In order to cause you to make blood cells, you have these hemopoietic growth factors. What's the growth factor that causes you to make red blood cells?
That's the EO.
Yeah,
right?
EPO, erythropoietin. What causes you to make white blood cells? Cytokines. And then what causes you to make platelets?
Trombone.
Thrombopoietin, right? Speaking of platelets, where do they come from? Megakaryocytes that do what? That explode, right? Into like thousands of pieces, and every little piece becomes a platelet, right? All right, let's talk in more detail about the red blood cells. What's this appearance of a red blood cell? What does it look like? Biconcave disc. What can you say about what's not inside of a red blood cell? There's no nucleus. There's also no organelles to speak of, right? Instead, there's lots and lots of what? Hemoglobin. So what's the function then of your red blood cells? To carry oxygen around your body, okay? How much hemoglobin is in one red blood cell? 280 million. The class this morning, I didn't get to tell my joke to you guys. The class this morning didn't know that answer, so I gave them a multiple choice. So they could either pick 3 or 280 million. And they picked 280 million, right? How long do red blood cells live? 120 days, not a second longer. Where do they go? Where do they go to die? Or the liver or the spleen, right? Macrophages take them out. So when you go to the liver or the spleen, the red blood cell dies there. You got to break down the hemoglobin. What's the first step in breaking down the hemoglobin? Remove the heme from the globin, right? Separate the word. Remove the heme from the globin. What happens to the globin when you break it down? It becomes amino acids that you can just recycle, right? What about the heme? The first step in breaking down the heme is to remove the what from the heme? Iron. What becomes of that iron?
It goes into the liver.
Yeah, it can be recycled. So you can attach it to a transport protein called transferrin, and then you can store it in the liver, attached to a protein called ferritin. And then when you want to make more red blood cells in the red bone marrow, you can take it out of the liver, again, attach it to transferrin, send it to the red bone marrow, and basically recycle it. What becomes to the heme that no longer contains the iron? It gets converted into bilirubin. Bilirubin has what kind of a color to it? Yellow, and it's responsible for the coloration of what?
Bile.
Your urine, your stool, also the nasty yellow color of bruises that you get after a few days, right? That's all due to bilirubin. All right. What's the name for young run? So, okay, we already established that red blood cells, mature red blood cells, don't have a nucleus. They don't have any organelles. What's the name for the young red blood cells that you might see about 1% circulating in your blood? Reticulocytes, okay? Now reticulocytes, they become reticulocytes when the precursor cell called a proerythroblast gets rid of its nucleus. So while a red blood cell is developing, while it's a proerythroblast, it still has a nucleus, but it ejects that and then it becomes a reticulocyte. Reticulocytes don't have a nucleus, but they do have some organelles, but eventually they lose the organelles and then they become your mature red blood cells, right? White blood cells. Do white blood cells have a nucleus?
Yes.
Yeah. In fact, they usually have a weird looking nucleus that's in multiple lobes, or at least they oftentimes do. What's the main function of your white blood cells? Fight infection. Now, white blood cells typically are not just hanging out already in a tissue, just waiting. Instead, they're circulating, and then they have to be called to the area. What's that? process called chemotaxis, where you release a chemical to attract it there? And then what's the process called where the white blood cells actually squeeze through the wall of the blood vessels? That's emigration, or another name for it is diapedesis, or a third name for it is leukocyte extravasation. Good. All right, good. That sounds really good. Now, for the white blood cells, they come in two types based on their appearance. If you have granules, you're called a what? Granular leukocyte. And if you don't have granules, you're called a loser. No, you're called an agranular leukocyte. And which are the granular leukocytes? Neutrophils, basophils, and eosinophils. So all the phils are the granular leukocytes. And then what are the agranular leukocytes?
Monocytes.
Yeah, lymphocytes and monocytes. All right, so let's go through these white blood cells in a little bit more detail. First off, we have the neutrophil. Neutrophil, what do they look like under the microscope? They have multiple lobes, right? They have like 2 to 5 lobes to their nucleus, right? That's a big thing. And what do neutrophils do? What are they good at? Destroying by what? Yeah, what's it called? There you go, phagocytosis. Neutrophils are great at phagocytosis. Along with cells called macrophages, they are the main phagocytic cells in the body. The difference between neutrophils and macrophages, neutrophils are circulating in the blood. Macrophages are already there. They're kind of like the local police force. They're already there, but they're both really good at phagocytosis. What can you say in terms of numbers? Compared with other white blood cells, the neutrophils are the whatest? They're the most common, right? What's the second most common? Lymphocytes. The third most common is monocytes, then eosinophils, and then bananas, right? That's right, basophils. Good. Yeah, never let monkeys eat bananas. Speaking of the eosinophils, what do they look like under the microscope?
Headphones.
They got earmuffs or headphones, whatever you want to describe them. What about in their cytoplasm? Yeah, big, chunky, pink or reddish granules there. What are they good against? Worms, like earthworms? No, parasitic worms. Don't be hating on the earthworms. Basophils. Basophils are the least common. What do they look like under the microscope, allegedly? Not that we ever saw one, but what do they look like? Big, chunky, purple, or even like almost blackish dots, right? Granules. They have a nucleus, but it's really hard to see it because the dots are so big and chunky and purple, and they're all over the place. What's inside the granules of the basophil? Histamine, heparin, and serotonin, right? Histamine and serotonin are inflammatory chemicals. They promote hypersensitivity, allergic reactions. What's heparin? Heparin's actually a blood thinner, which sometimes you don't want your blood to clot too soon because it can block the white blood cells from getting to the area, so that's the purpose of that. What's the name of the connective tissue cells that are similar to basophils? Mast cells. They also release histamine and heparin, and then in addition release chemicals called proteases. Monocytes. What can you say about the appearance of monocytes? What do they look like under the microscope? Not earmuffs. They look like, yeah, kidney bean shaped nucleus or a horseshoe shaped nucleus. What about their size? They are the biggest white blood cells that you have. Now, you don't have high numbers of monocytes because they are constantly leaving the circulation and they turn into the macrophages. All right, so their numbers aren't that high. Lastly, we have the lymphocytes. They're the second most common. What can you say about their size?
Small.
They're the smallest ones. What do they look like under the microscope?
That's like a.
They have a big purple, first of all, they're very round. They have a big round purple nucleus that takes up almost the entire cytoplasm, so you just see a thin rim of cytoplasm. In terms of their fighting off infections, what sets them apart from other white blood cells? They identify specific antigens. They are part of what's called your specific or your adaptive or your acquired immunity. It goes by a couple of names, but they identify specific antigens as opposed to just sort of blocking against anything that remotely seems foreign. These guys actually go and try to figure out what the specific bacteria or virus is that you're infected with. What are the three main types of lymphocytes?
B
B cells, T cells, and natural killer cells. All right, that was the white blood cells. As for the platelets, again, they come from these huge cells called megakaryocytes that rupture into thousands of pieces. What's the function of platelets? What do they do? Yeah, they help with hemostasis, right? They do a number of things that promotes hemostasis, which we'll talk about here in a moment. Bone marrow transplant, cord blood transplant, those are methods of treating people that have diseased bone marrow, first by destroying their bad bone marrow, and then by infusing some good bone marrow, either provided by another person, or depending on the disease they have, sometimes they can serve as their own donor. All right, hemostasis. So what does hemostasis mean? Yeah, stop blood, or hold, like hemo means blood, stasis means like steady or not moving. So holding the blood steady, like preventing blood loss after you've like damaged a blood vessel. After you've cut through the wall of a blood vessel, you need to control it so you don't lose too much blood, right? Three mechanisms that are involved in hemostasis. What was the first one? Vascular spasm. What does that mean? That means like constriction, right? That means constricting the blood vessel upstream from where the hole is, right? So that you have decreased blood flow going by that hole so you don't lose as much blood, right? What's the second mechanism?
The cork.
Yeah, the platelet plug, right? So when you damage the wall of the blood vessels, platelets will start sticking to that area. They'll call in other platelets, which will start sticking to them. Pretty soon you got a whole bunch of platelets stuck together. They form this platelet plug, which might do a pretty good job at like blocking off the hole, right? But then what's the third step? The actual blood clotting or the coagulation, right? And that one we spent a fair amount of time talking about. So with coagulation, it's a series of chemical reactions where whatever you get at the end of one chemical reaction then leads to the next chemical reaction, and the next, and so on and so forth. It's divided into 3 stages. I told you that you don't need to know every little chemical reaction that's in each stage, but you should know what the chemical is that you get at the end of each stage, okay? So what do you get at the end of stage 1? What chemical? Prothrombinase. And then prothrombinase is going to be used in stage 2 to convert prothrombin into thrombin. So at the end of stage 2, you get thrombin. And then the thrombin is used in stage 3 to convert fibrinogen into fibrin, and then also to activate factor 13, which will help to strengthen the fibrin. So at the very end of the whole thing, you should have this protein called fibrin that makes this kind of net structure that should attach itself to the edges of the hole in the blood vessel, and then gradually sort of pull those edges together so that it can heal itself. In the meantime, that net will help to trap, red blood cells, white blood cells, platelets, so that you don't lose any further of those things. So that's the purpose there. The most complicated of the 3 stages is the first stage, because there are 2 pathways that you can follow. What are the names of the 2 pathways? Intrinsic and extrinsic. Which pathway do you follow if you have like a severe damage, like an actual hole through the blood vessel wall? Extrinsic pathway. And then if you have lesser damage, like not necessarily a full hole, then you follow the intrinsic pathway. It really doesn't matter which pathway they follow though, because you still get prothrombinase at the end of it, right? Now, blood clotting is great and all, but it is a positive feedback system, which means clots can get bigger and bigger and bigger. So they can be dangerous. You have something called the fibrinolytic system that's in charge of looking for unnecessary, inappropriate clots and breaking it down. There's a protein built into the clots called plasminogen that is actually kind of a self-destruct protein that can get converted into plasmin, which will then actively dissolve the clot before it hopefully gets out of hand. Other things that help prevent abnormal clotting, endothelial cells and white blood cells produce a chemical called prostacyclin that inhibits platelets from sticking to the walls of the blood vessels. So when you have normal, healthy blood vessels, platelets shouldn't be sticking to the walls, mostly due to this prostacyclin that's being released. As soon as you damage the walls, there's less of this chemical in that area, and then platelets will start to stick to it and become attracted, etc. What is the name for an abnormal clot? That's a thrombus, right? Or that's the singular, or thrombi is the plural. And what type of blood vessels do you usually see thrombi in? Yeah, legs, and what type of blood vessels in the legs? Arteries or veins? Veins, okay? The blood flow there is a little bit more sluggish, and that, bad things happen when the blood just sits around. Clotting factors can start to interact, and next thing you know, you've got a blood clot. So good blood flow, walking around really helps, because remember, you learn this later in chapter 21, you've got the skeletal muscle pump that kind of squeezes blood through your veins. So the more you use your muscles, the more it'll keep the blood flowing through your veins, and the less likely you'll be to get a form of thrombus, right? Now, thrombi suck for a number of reasons, but one of the biggest concerns is that a portion of it will break off and then travel. What's that called when it breaks off and travels? That's an embolus. And if you had a clot in one of the veins of your legs and it broke off and embolized, where would it get stuck? Probably the lungs, right? That would be the next smallest spot, and you get a PE, a pulmonary embolism, right? What if you had a clot forming in your heart? Like, for example, the left auricle of the heart is a dead end space, basically, and in people that have arrhythmias of their heart, sometimes the blood can sit around inside the auricles. If you had a clot forming in the left auricle and it broke off and it embolized, where would it go? It'd go up to the brain, right up to the carotids and into the brain, and you get a stroke. Okay. All right. Blood groups. So, bless you. Blood groups are based on the markers that you have on the surface of your red blood cells. Okay. These markers are referred to as antigens. We'll talk all about antigens in the lymphatic system chapter. But anyway, you got these different markers on the surface of your red blood cells. And there's two main blood typing systems that we use. What are the two main blood typing systems that we use? There's the ABO system, and then there's the RH system, right? What are the four blood types that you get with the ABO system? A, B, AB, and O, right? And whatever type you have, that refers to what antigens you have on the surface of your red blood cells, okay? So person with A has type A antigen, person B, AB has both, and then type O, remember, has neither A nor B on the surface. Now, the weird thing about the ABO system is whatever antigen you have on the surface of your red blood cells, what will you find in your plasma? You'll have antibodies against the opposite type, right? And you always got to keep that in mind. Which blood type is considered the universal donor? O, right? Remember, you can give O red blood cells to anyone because there's no antigen on the surface, so it doesn't matter what they have in their plasma, it's not going to react. And who's the universal recipient? AB, because they don't have any antibodies in their plasma. They can get red blood cells from anyone. The other system is the RH system. If you have the RH antigen, then you're considered what? Positive. You can say RH positive, or by convention, we just know if you say the word positive, it means that you're talking about the RH. So if you have it, you're positive. If you don't have it, you're negative. Now, ordinarily, in a normal, regular person, whether you're RH positive or RH negative, do you have any antibodies against the RH in your plasma? No. A normal, regular person, it doesn't matter whether you're RH positive or RH negative, most people do not have anti-RH antibodies. But they can develop them, right? And what's the scenario that we talked about where you develop pregnancy, right? Specifically, you've got a RH negative mom who's carrying an RH positive baby, and at the time of delivery, things get sloppy, blood gets mixed, people are screaming. Don't worry, the doctors and nurses are getting paid, all right, so all's good there. But blood's being mixed, there's a good chance of that, and if the mom's blood is exposed to a little bit of the baby's blood, that's going to trigger her system to start making anti-RH antibodies. Is that a problem for that baby? No, that baby's out the door. That baby doesn't have to worry about it. Who's it a problem for? Next baby. If she's pregnant again with another RH positive baby, maybe she's not. Maybe she broke up with the guy for the first baby, and she's now dating a new guy. It's entirely possible, right? It could happen. Anyway, but if it's another RH positive baby, those antibodies from the first pregnancy could cross the placenta and destroy those red blood cells, and that would be devastating. So what do you give them on to prevent that from happening? Rogam, which is basically a commercially prepared antibody that you give to the mom. It'll seek out any of the baby's red blood cells that might have gotten into her circulation, and it will destroy them before her own body has a chance to react against them and form anti-RH antibodies. Okay? All right. What's the word that means a condition in which the oxygen carrying capacity of the blood is reduced? That's anemia. So anemia might be due to, having low numbers of red blood cells. Maybe your red blood cells are being destroyed early. Maybe you've got a disease where in your bone marrow where you're not making enough red blood cells. Maybe you've just simply hemorrhaged, like you've been in a trauma situation and you lost some blood, so you don't have them that way. There can be a number of causes of anemia. What's the opposite condition when you have too many red blood cells?
Polycythemia?
Yeah, polycythemia. And when can that happen?
If you inject erythropoietin.
Yeah, that's right.
You get like a boost of red blood cells.
That's right. If you inject yourself with erythropoietin, or if you just move to what kind of altitude?
Denver.
Denver. It can be other places. You don't have to go to Denver, but if you want to, someplace high, right? Don't go to some little hill someplace and be disappointed when your numbers don't go up. I want my money back. All right. All right, that's all I wanted to say about that stuff. Any questions about the blood stuff? Yes, Corey.
Is the intrinsic or extrinsic pathway faster? It's a fix. Which one is faster?
The extrinsic is faster. Yeah, it doesn't have as many steps, and it kind of makes sense because it's sort of like your body's like, wow, if it's the extrinsic, this must be severe damage. So let's make this fast. This step as fast as possible. Yeah. Good question. All right. Next, we have the heart. If you don't like this chapter, good news. There's only 5 questions from this chapter on the final exam. I'm still bitter about that. I think that's I just think it's I can say what I want. I'm tenured. They can't fire me. No, it's just like, why do we have 36 questions from the endocrine system and then 5 from the heart? It doesn't make any sense to me.
Protest.
I tried. I don't know. Anyway, all right. So let's talk about this. The heart, then. Where's the heart located? Mediastinum. And what's the pointy part of the heart called? Apex. What direction is pointing? Down and to the left, right? So it's directed anteriorly, inferiorly, and to the left. What's the flat part of the heart called?
Base.
The base. Good. What's the name of the membrane that surrounds the heart?
Pericardium.
Yeah, the pericardium. Let's go through the layers from outside in. What's the outermost layer? Fibrous pericardium. It's made up of a dense, irregular connective tissue. It's really strong. Does it stretch? No, it won't stretch. It's like a leather bag, right? What's the layer that's then deep to the fibrous pericardium?
Serous pericardium?
Yeah, not yet. It's the parietal layer of the serous pericardium is next, right? And that's going to be a nice smooth membrane. Then what do you have next? The pericardial cavity. And how much fluid is usually in there?
10 to 15.
No, there's a little bit. There's 10 to 15 milliliters in there that act like a lubricant, right? But if too much fluid fills up there, what's that problem called? Cardiac tamponade, right? When you start to basically constrict the heart and prevent it from beating, right? After the pericardial cavity, what's the next layer you have? You have the visceral layer of the serous pericardium, or the other name for it is the epicardium. You usually use the word epicardium, though, when you're talking about the layers of the heart wall. So that layer doubles for both being part of the pericardium and part of the heart wall. So let's talk about the heart wall then. The outermost layer of the heart wall is the epicardium. What's the middle layer? Myocardium. What's in the myocardium? Muscle, right? That's usually the thickest layer. And then what's the innermost layer? Endocardium. All right, good job. How many chambers does the heart have?
4.
Good. How many chambers does the heart start with when you're an embryo? 1, and then eventually it has to partition itself off into the 4 chambers. Which chambers are nicknamed the receiving chambers? Yeah, the atria. And that's because they're receiving blood from the rest of the body. What's the name of the little ear-shaped structures I mentioned that are attached to it?
Auricles.
Auricles. They're hollow on the inside. So they help to raise the amount of blood that each atria can hold, right? But again, in a person that has heart rhythm problems, they can be a dangerous area because the blood can that's like a dead end. The blood doesn't move around in those auricles as well. And there's actually an operation called a Watchman procedure where they actually sort of block off the opening of the auricles just so that it's not a dead space where blood can be. Hey, don't worry, I'm not going to ask you about Watchman procedure. Anyway, and then the other chambers that are the pumping chambers are the ventricles, right? Now, when you look at the wall of the myocardium, there's going to be different thicknesses. First of all, who has a thicker myocardium, the atria or the ventricles? Ventricles. And then between the ventricles, who has a thicker one?
The left ventricle.
The left ventricle. Why?
That's the word.
It has to work harder, right? It's got to pump blood out to the rest of the entire body, whereas the right ventricle, it just has to pump it up to the lungs, right? Then we talked about the valves. How many valves do you have in the heart? 4 valves. What's the name of the valves that separate the atria from the ventricles?
The tricuspid.
Yeah, the AV valves, or the atrioventricular valves. And the one that separates the right atrium from the right ventricle is the tricuspid valve. The one that separates the left atrium from the left ventricle is the bicuspid valve, also known as the mitral valve, also known as the left AV valve. Yeah, sorry. All right. Oh, speaking of the AV valves, they're really thin. So what are the names of the things that are attached to them to kind of hold them in place?
The chordae tendinate.
Yeah, the chordae tendinate. The other valves are the semilunar valves. What's the name of the semilunar valve on the right side? That's the pulmonary valve, and on the left side, the aortic valve. Those are kind of like the doors out of the heart, right? Those are the doors as you're leaving the heart. Do they have chordae tendinae?
No.
No, they have thick enough cusps that they don't need the chordae tendinae. All right. Now, the myocardium itself, made out of cardiac muscle, has a really high demand for oxygen and glucose because it's working so hard. And so it has to have its own dedicated set of blood vessels to deliver the blood and the oxygen and the glucose. What's the name of the dedicated blood vessels for the heart itself? The coronary vessels, right? How many coronary arteries? What are the 2 main coronary arteries called? Left and right coronary arteries. What are the branches of the left coronary artery?
The LAD.
The LAD and the
The circumflex.
circumflex artery. What are the branches of the right coronary artery? Posterior interventricular branch and the marginal artery. Good. As for the veins, you have some important veins that kind of follow alongside of those arteries. What's the name for the vein on the back of the heart where all the deoxygenated blood collects?
Coronary sinus.
Coronary sinus, right? That's the collecting spot for all of the used blood. All right. Cardiac histology. So when you look under the microscope, what's one key feature that sets heart muscle apart from like skeletal muscle or smooth muscle? Intercalated discs. Those represent the attachment points between one cardiac muscle cell and another cardiac muscle cell. And if you could look inside of them, the intercalated discs, you'd find little gap junctions that allow the cytoplasm to basically be shared between the different cardiac muscle cells. Anyone remember what the purpose was of those gap junctions? What it allows the muscle cells to do? They send very fast electrical signals, okay? And that's really important. It's all about coordination, right? Everybody has to be on the same page. You want all the heart muscle cells basically squeezing at the same time and then relaxing. It has to be very well coordinated, so you need fast electrical signals, right? Speaking of electrical signaling, what's that property that 1% of heart muscle cells have where they can generate their own beat?
Autorhythmicity.
Autorhythmicity, good. The pathway of the electrical signaling in the heart. Where does the electrical signaling begin in the heart?
The SA node.
The SA node, the sinoatrial node. What's the nickname for the SA node?
Pacemaker.
It's the pacemaker of the heart. From the SA node, the signal will spread out to both atria. So the SA node's in the right atrium, but the signal will also spread to the left atrium. And then at the same time, the signal will go downward and it will stop off where?
AV node.
AV node. What important function does the AV node have? Slows down the electrical signal. Why?
So it can catch up.
Kind of so it can catch up, or so that the atria are squeezing while the ventricles are relaxed. okay? You don't want the signal to get to the ventricles too soon, or they'll start to contract when the atria is starting to contract, and then the blood won't flow very well. So you want it's to delay it. Where does the signal go after the AV node?
The AV bundle.
Yeah, the AV bundle, also called the bundle of His. There's a left and right branch to it. After there, where does it go?
The pitching.
Purkinje fibers, also called the subendocardial branches, and then the signal will be to the ventricles, and they'll start to squeeze. Okay. Cardiac muscle action potential. Cardiac muscle has a very long refractory period. So the refractory period is longer than the contraction itself, which basically then forces the heart to alternate between contracting and relaxing. You can't get sustained contractions in cardiac muscle the way that you can in skeletal muscle. What was that term for sustained contractions that you had with skeletal muscle?
The tetanus.
That's tetanus, right? You can't get that with cardiac muscle, which is a good thing, because the cardiac muscle is a pump, and pumps are only good if they have both a contraction phase and a relaxation phase, right? What's the name of the medical test that you do to evaluate someone's electrical activity of their heart? Yeah, an ECG or an EKG. What's the first wave on an EKG? P wave, and what does that represent? Atrial depolarization. So that's when the signal is first going through the atria. What's the next wave?
QRS.
The QRS wave. What does that represent? Ventricular depolarization and atrial repolarization. So it represents when the signal is first going through the ventricles, but then it also represents when the atria are resetting themselves electrically to get themselves ready for the next beat. And then what's the last main wave?
T wave.
The T wave. And what does that represent?
Repolarization.
Ventricular repolarization. They're getting themselves reset. Now, in some people, after the T wave, you can see a what? A little U wave, and that is thought to represent
The end.
the end. That's thought to represent depolarization of the papillary, repolarization of the papillary muscles. But not everybody has a U wave. It's not usually a big deal. Although, in some people that are on digoxin, which is a medication, it can represent like their levels are being too high, the digoxin levels are too high, and you need to come down on the medication. All right, cardiac cycle represents the actual squeezing and relaxing of the heart. What's the first step of the cardiac cycle? Atrial systole. The atria are contracting, blood is being pushed from the atria through the AV valves into the ventricles. Semilunar valves are closed during the stage. What's the next stage? Isovolumetric ventricular contraction. So the ventricles are just starting to contract, and as soon as they start to contract, the blood's going to try to go backwards, but that's going to cause the AV valves to slam shut. That slamming shut of the AV valves during this phase is what creates what? The first heart sound, right? The S1 heart sound, right? Now, are the semilunar valves open yet?
No.
No. The ventricles are just starting to contract. They haven't generated enough pressure to overcome the pressure that's on the other side of those semilunar valves. By the way, what was the name of that other pressure that's on the other side of the semilunar valves that it has to overcome? This came up in the blood vessel chapter. Actually, no, sorry. It comes up in this chapter, but it comes up later. I'll give you a hint. It starts with an A. It rhymes with Bafterload. Afterload. On the other side of the semilunar valve, that's the afterload. So remember, afterload is the bad guy. Afterload, a high afterload means that the heart has to work extra hard to overcome that to get those semilunar valves to open, right? Anyway, sorry, that's stage 2, isovolumetric ventricular contraction. All doors, or all valves, whatever you want to call them, they're all closed, so the volume of blood stays the same during that stage. What's the third stage?
Ventricular ejection.
Ventricular ejection. So as the ventricles continue to contract, eventually they will overcome that afterload, and that's when the semilunar valves open and blood gets ejected from the ventricles. Does all the blood that's in the ventricles get ejected?
No.
No. What's the name for the part that does get ejected? That's called the stroke volume. What's the name for the part that stays behind? Not end diastolic volume, but end systolic volume, or it also goes by another name. Residual volume. Okay. Remember, that's one of the benefits of like exercising and being in good cardiovascular shape. You'll have a lower residual volume. You will pump more out with each squeeze when your heart's in shape. Okay. What's the fourth stage? Isovolumetric ventricular relaxation. So the ventricles are starting to relax. As soon as they start to relax, blood's going to flow backwards, or try to flow backwards, in the pulmonary trunk and in the aorta, but it's not going to be able to go backwards because the semilunar valves will slam shut. So during this phase, semilunar valves slam shut. That's going to create what then? That's going to create the second heart sound, the S2 heart sound that you hear. Now, are the AV valves open yet? No. The heart has not relaxed enough yet for the AV valves to be open. So just like step 2, step 4 is another closed door phase. All the doors, all the valves, whatever you want to call them, they're closed. So the volume of blood that's in the ventricle during that stage does not change. That's why it's called isovolumetric. And then what's the fifth stage?
Passive ventricular filling.
Yeah, passive ventricular filling. So as the ventricle continues to relax, the pressures in the ventricles will be so low that the AV valves will naturally open and blood will passively flow from the atria into the ventricles. Okay. All right. What's it called when you listen to body sounds with a stethoscope? Auscultation. Good. Again, in a normal person, there's 2 heart sounds. There's the S1 that represents the AV valves closing, and then there's the S2 that represents the semilunar valves closing. Do valves opening usually make a sound? No. When valves open, that usually doesn't create a sound. We then shifted gears and did some math stuff, and we talked about the cardiac output. Instead of telling me the formula, just describe the cardiac output. What does the cardiac output mean? It's the blank, blank, and blank. It's the amount of blood that's pumped out of the heart each minute. That's the cardiac output, okay? And what was the formula for the cardiac output? CO, all right, we're off to a good start. CO equals SV
Times heart rate.
right? So SV is the stroke volume, and CO is the cardiac output, and HR is the heart rate. So this is the amount of blood with each squeeze, right? Stroke volume. And then this is like the number of squeezes per minute, right? The heart rate. What were the 3 factors that influenced the stroke volume? Yeah, preload, afterload,
Contractility.
and actually, let me go in a different order. Preload, contractility, and afterload. I could go in any order, but I'm going to go in this order because I want to. All right. And then things that influence the heart rate, the autonomic nervous system, chemicals, and then other factors. So what's the preload? How much the ventricles are stretched before they contract. And in general, the more that they're stretched, the better, the stronger the contraction is going to be and the higher the stroke volume is going to be, okay? How do you stretch the ventricles? You just put what? Put more blood in, okay? So in general, as preload goes up, the stroke volume goes up. So it's a direct relationship. As preload goes up, stroke volume goes up. As preload goes down, stroke volume goes down. It's a direct relationship. Contractility refers to the inherent squeezing. How strong is the actual squeezing of the heart, okay? And again, the stronger the squeeze, the higher the stroke volume is going to be. So it's also directly related. So as contractility goes up, stroke volume goes up. As contractility goes down, stroke volume goes down. By the way, this is a question that confounded the class this morning, mostly because I didn't give the answer. So it's on me. It's on me. What's the name for medications and things that increase the force of contractions? They are called contraction increasers. No, that's not nearly cool enough. They're called, what do you call them? But no, that's a good example of the next question I was going to ask. Keep that in your mind. Positive inotropic agents. Positive inotropic agents are ones that increase the force of contractility. Okay? And then what do you suppose the ones that decrease contractility? Negative inotropic agents, and beta blockers are an example of a negative inotropic agent. Okay. Anyway, so far, these 2 guys are directly related to stroke volume. What about the afterload? Is the afterload directly related to stroke volume? No, it's inversely related. The afterload is the bad guy, okay? The afterload is the pressure on the other side of those semilunar valves. If you want to open the semilunar valves to eject blood during that third stage, you got to overcome the afterload. So as afterload goes up, the stroke volume goes down, okay? It means that the heart has to work harder to pump its blood out. So a high afterload is bad. You want a low afterload, then the heart doesn't have to work as hard and it'll get a better stroke volume, right? Yes?
Would you say it's pushing the valve shut in a way? That's
Yeah, yeah, that's exactly right. That is how I'd say it. It's pushing the valve shut. Yeah. Yep. All right, factors that influence the heart rate. Autonomic nervous system. What does the sympathetic division do to your heart rate?
Accelerates it.
Increases it. What does the parasympathetic do to it? Decreases it. What's the cranial nerve that delivers the parasympathetic signals?
The vagabundo.
Yeah, 10, the vagus nerve. Chemicals, that can refer to things like hormones, right, such as epinephrine and norepinephrine that increase the heart rate from the adrenal medulla. It can also refer to like cations, like sodium and potassium. What does potassium do to electrical signaling? It like stops it, right? It's really bad, obviously. And then some other factors just to bear in mind. Who are the individuals that have a normal, really fast heart rate? Yeah, newborns, all right? Over 120 is like normal for a newborn, right? I kind of mentioned this before. Exercise. If you're a person that's in good cardiovascular shape, do you have a fast or a slow heart rate? You have a slow heart rate usually because your heart is so efficient. It's pumping so much out with each beat that it doesn't have to beat a lot and it can still get a good cardiac output, right? So, you see that. All right. All right. Where am I going? Okay. One second. Yeah. Oh, the center that actually controls your heart and controls your blood vessels is the cardiovascular center. Where's the cardiovascular center located? In the medulla. All right. All right. Next, coronary artery disease. Coronary artery disease is usually due to atherosclerosis building up in those coronary vessels. It's the leading cause of death in the United States each year. Risk factors for coronary artery disease: high cholesterol. What kind of cholesterol is bad cholesterol? The LDL cholesterol is the bad cholesterol, right? High blood pressure or hypertension, right? Cigarette smoking, obesity, diabetes, type A personality.
Actually, I wanted to ask about that last week. I forgot to ask. Wait, so how exactly does the type A personality lead to
I think what it does is it leads to higher blood pressures usually. So by leading to a hyper blood pressure, that in turn leads to atherosclerosis and then coronary artery disease. I think. Remember, you've got a connection between like your limbic system in your brain and the cardiovascular center. So signals from there, from emotions, like competitive emotions and things like that, presumably could activate like your sympathetic system like full time. You know, just being sort of driven and competitive can affect that sympathetic system. So you're turning it on. That in turn raises your blood pressure, which over time then can lead to like coronary artery disease. Yeah.
I think that's fake. I mean, I know you're the messenger, so I'm not gonna kill you. I know you're
Yeah.
the messenger, but I think that's fake. I
Yeah.
don't think that's true, but
Okay.
I'm not team the messenger, but
Then why don't you think it's true?
because I mean, like, if you look at throughout society, like, there's a bunch of people who are like high achievers.
Yeah.
And they never actually have like you never see them have like issues with like high blood pressure.
They also might
Or
be more.
they pass away.
Sure,
It's not related to like cardiovascular at all.
Mm.
they do.
They might be more likely to be like
Oh, you're
doing
fine,
other
sorry.
things to stay healthy. That would combat
Yeah, they could.
it.
Yeah, it could be offsetting it too. Yeah.
Wait, but you can get funny
That's
something.
just my point.
Funny
They don't
girl,
have
Joe.
they don't have high blood pressure.
Well, they might have high blood pressure, but maybe they're, you know, I don't know if they're really successful. Maybe they got good
But
medical
the
care.
thing is, like, Okay. Yeah, okay, yeah. So they might have high blood pressure, but because they're driven, they're probably like disciplined, they're committed, they're like on top of things.
Yeah.
They're probably like the type of people that they go to like regular doctor visits.
That's what I'm saying, yeah, that
So,
that
like-
could be a benefit, right?
So like, yeah, they have high blood pressure, but they don't actually have it. Like, you know,
They're prone to it, yeah, if they didn't treat it, right, if it was untreated, they would have high blood pressure.
But there's people who are like, let's say type B personalities. I'm sure they have high blood pressure
Type
too.
A person.
Yeah,
But they're like complacent.
yeah, you can still die even if you're a type B personality. Yeah, yep.
So I mean, like, so, I don't know. Yes.
All right, fine.
Stalling over here.
We'll just agree to disagree. And then a sedentary lifestyle. All right, next, before I run out of time here. Chapter 21 was the blood vessel chapter in hemodynamics. What's the name of the blood vessels that carry blood toward the heart? Veins, and carry it away from it are arteries. In terms of the layers in the blood vessel wall, remember most blood vessels have 3 layers. What's the outermost layer?
Tunica externa.
Tunica externa, and that's mostly made of elastic and collagen fibers that kind of hold the blood vessel in place and anchor it. What's the middle layer?
Tunica media.
Tunica media. What kind of tissue is usually in the tunica media?
Smooth muscle.
Smooth muscle, and that's where you'll send signals with your autonomic nervous system that then control the diameter of your blood vessels, right? And then what's the innermost layer called?
Tunica interna.
Yeah, tunica interna, also known as the tunica intima, okay? Now, in terms of the types of arteries, the biggest arteries you have are called elastic arteries, and what's the best example?
Aorta.
The aorta, right? There's a lot of elastic fibers, it's a very stretchy wall. Next biggest are muscular arteries that have a fair amount of smooth muscle in their tunica media. Those would be things like the brachial or the radial artery in your arm. Then we took a little break. We talked about it in anastomosis. What are anastomoses?
Union of vessels supplying blood to the same body tissue.
Exactly.
Yeah, is that what you say, Corey?
Yeah.
All right, that's good. Yeah,
Sorry.
You're still so polite, Corey. Yeah, he's just don't listen to these guys over here. They're just awful. Anyway, yeah, that's right. So it's a. I'm taking that as Corey's credit because he was going to
Yeah.
say the exact same thing and you just blurted it out.
I'm sorry.
Stole his thunder. All right. Anyway, yeah. And what's the what's the purpose of an anastomosis? What does it do? Yes, Corey. Yes, Corey.
It gives an alternative route for blood supply.
That's right. It's a safety mechanism that gives an alternative route to get blood to the same tissue, right? And the fancy name for that alternative route is called
Collateral
collateral
circulation.
circulation. All right, very good. Sorry, I digressed there. So after the muscular arteries, the smallest type of arteries you have are called what?
Arterial.
Arterioles. The arterioles are sometimes known as the resistance vessels because, remember, when you pass, once the blood can squeeze through the arterioles, there's a huge drop off in pressure. When you're in front of the arterioles, you're on the artery side of things, and it's a very high pressure system. When you squeeze through the arterioles, you're essentially into the capillaries and the venous side, and it's much lower pressure on that side. Okay. So the arterioles, they're really important. There's a big drop in pressure. They have the biggest influence on both local blood flow and on overall blood pressure. And then you come to the capillaries. The capillaries are where what happens? Exchange. That's where you exchange oxygen, glucose, all the other materials that you think of. What are the 3 categories of capillaries? What's the most common type of capillary? Continuous. They're continuous are also the least what? Permeable, right? They also are the hardest to pass through the walls. They don't have any big holes or anything. I mean, they still let stuff like important stuff pass through, but they're the least permeable. What's one step up in permeability?
Fenestrated.
Fenestrated capillaries. What did fenestrated mean?
Windows.
Windows. They have little pores that'll allow bigger things like proteins to pass through potentially. And then the most porous type of capillaries are the what? Sinusoids. And where were some places that you saw sinusoids?
Liver and spleen.
Liver, spleen, also red bone marrow. It's a good place for it. Veins then, what can you say about the walls of veins compared to arteries?
Thin.
They're thinner. Why are they thinner? Lower pressure, right? Again, once you're on that side of things, the pressures are very low. You don't need big, thick walls over on the venous side of things. However, the lack of pressure there presents a problem, right? It makes it harder for the blood to flow over there. So what do veins have to kind of make sure the blood goes in one direction? Valves, okay? They also have some other things that help the blood move along, but we'll talk about that later when we talk about venous return, right? Now, capillary exchange, that's when you exchange materials between the capillaries and the tissues. What is the most important method of capillary exchange? What'd you say? No, that's not the most. This is literally a direct quote from the PowerPoint. The most important method of capillary exchange is simple diffusion, right? That's just the natural tendency for a substance to pass from the side of the membrane where it's in high concentration to the side where it's in low concentration. Simple diffusion is how oxygen, carbon dioxide, glucose, amino acids, that's how they all get into or out of the capillaries, okay? Now, bulk flow, though, we did spend a lot of time talking about bulk flow. Bulk flow is how you pass water and small solutes dissolved in that water, how you pass that between the capillaries and the tissues and back again. Now, when you go into a capillary bed, is fluid going to be leaving the capillary or coming back into the capillary as you're entering into a capillary bed? It's leaving.
Yeah.
And what's the name for that when it's leaving?
Filtration?
That's filtration. As you move along the capillary bed, by the time you come to the end, most of that fluid is going to come back. What's that called when the fluid comes back?
Reabsorption.
Reabsorption. Most comes back. What's the percentage that doesn't come back?
1%.
Not more than 1%.
2%.
It's about 13 more than 2%. 15%. 15% is going to not come back. Is that a problem? Does that 15% just hang around and build up in the tissues? No. What happens to it?
Goes to the lymphatic system.
Lymphatic system picks it up. It acts like little drains that collects that 15%, and then ultimately the lymphatic system will dump it back into your subclavian veins. So it will get back to your blood eventually, okay? Remember that there are 4 pressures that are governing all of this stuff. 2 of the pressures promote filtration, and then 2 promote reabsorption. Blood hydrostatic pressure and interstitial fluid osmotic pressure promote filtration. Blood colloid osmotic pressure, interstitial fluid hydrostatic pressure promote reabsorption. The strongest pressure, and the only one that actually changes, is the blood hydrostatic pressure. So bear that in mind. Okay. We then shifted to hemodynamics, which is basically the study of blood flow. In one word, what makes blood flow? Pressure, thank you. Pressure makes blood flow, specifically a pressure gradient, right? Blood will flow from where it's in higher pressure to where it's in lower pressure. And if you could test all the pressures throughout the system, there's one big pressure gradient, right? As you leave that left ventricle and you go into the aorta, that's where the highest pressure is going to be, in that ascending aorta. And then as you go around the body and eventually come back until you're just outside of that right atrium, that's where the lowest pressure is going to be, right? So it's one big pressure gradient. So pressure is what makes blood flow. What's the name of the factor that goes against blood flow?
Resistance.
Resistance, okay? And there were 3 things that influenced resistance. What's that word that means like the thickness of the blood?
Viscosity.
Blood viscosity. The total length of the blood vessels, right? That's going to be a factor. The more distance the blood has to travel, the higher the resistance will be. And then what was the third factor?
Size of blood vessel.
Yeah, the size of the blood vessel lumen, or the diameter of the blood vessel, whatever you want to call it, right? A blood vessel that's nice and wide open is going to have low resistance, and blood is going to want to go through that blood vessel, right? A blood vessel that's tightened up, that's vasoconstricted, is going to have a very small diameter, and blood's not going. It's going to have a high resistance, and blood's not going to want to go through that. It's going to try to find the path of least resistance, right? What was the name of the law that equated blood flow and pressure and resistance?
Ohm's law.
Ohm's law. Basically, it said that blood flow equals pressure divided by resistance, right? So as pressure goes up, blood flow goes up. As resistance goes up, blood flow goes down, right? So blood flow around the total body is called total blood flow, or another name that we learned for it already in the heart chapter is what?
Cardiac output.
Cardiac output. Cardiac output and total blood flow are the same thing. And in a normal person at rest, roughly what would their cardiac output be at rest? probably close to whatever their blood volume is. So around, if you've got 5 liters of blood, your resting cardiac output's gonna be around 5 liters per minute, okay? That's the total amount that's coming out of that left ventricle. Then your body has to decide how it wants to divide it up, right? How many of those 5 liters, how much of that 5 liters do you want to send to the kidneys? How much do you want to send to your stomach and your intestines, right? That's the distribution of the total blood flow, and that's all going to be dependent on how constricted or how dilated the blood vessels are. If you want more blood to flow to a particular organ, dilate the blood vessels that are going to that. That'll reduce the resistance and blood will flow to that organ. If you want less blood flow to an organ, tighten up the blood vessels, vasoconstrict. That'll increase the resistance and less blood will go there. It'll try to seek a different path, okay? All right. Arterial blood pressure. So when someone says blood pressure at the hospital, 99 times out of 100, they mean your arterial blood pressure, okay? When you put that cuff on someone, what's that cuff called? Or that device? A sphygmomanometer. When you put that on somebody, you're measuring their arterial blood pressure, okay? There are ways to measure like venous blood pressure and things, but those usually require more invasive catheters to be placed. In a general patient that's in the hospital, you're not gonna go to that trouble, but if they're in like an intensive care unit, you want as much data as possible, so you might put a special catheter in and then you could measure actually their venous pressure as well as their arterial pressure, okay? But anyway, when somebody just says blood pressure, they usually mean arterial blood pressure. What's the main determinant of your arterial blood pressure? It's simply, cardiac output is a factor that plays into it, but it's simply how much blood are in your arteries. Your arterial blood pressure is based on how much blood is in your arteries. The more blood in your arteries, the higher your blood pressure. The less blood in your arteries, the lower blood pressure. Cardiac output is what puts the blood into your arteries. So as cardiac output goes up, arterial blood volume goes up, and so does your arterial blood pressure. The other factor in that equation was the systemic vascular resistance. That refers to how tight those arterioles are. And if the arterioles are tight, then blood is essentially trapped in the artery side of things, and that's going to increase the blood pressure as well. Versus if the resistance is low, that means blood can move and leave the arteries and go into the capillaries, and then it doesn't count towards your arterial blood pressure anymore, okay? Keep in mind that when somebody does a blood pressure reading, usually they're going to do that thing blankety blank over to blankety blank, right? Like 120/70. What's the higher number? That's the systolic. So that's when the heart's contracting. What's the lower number? Diastolic. That's when the heart's relaxed. Sometimes, in some scenarios, like in the intensive care unit, they don't like to deal with 2 numbers, and they'll use an average. What's the name of that average?
Mean arterial pressure.
The mean arterial pressure, or the MAP, right? We then talked about venous return. What's the chamber in the heart where all of the deoxygenated blood comes back to? Right atrium. What are the 3 things that dump blood into the right atrium? And the coronary sinus. So inferior, superior vena cava, and the coronary sinus are the 3 things that are dumping in there. Now, in order to do venous return, remember, it's problematic because there's low pressures in the veins, so it's hard to keep the blood moving. We already mentioned the valves. They're going to help. But what were the 2 other things you needed to also help keep the blood flowing through the veins?
Skeletal muscle pump.
Skeletal muscle pump and
respiratory
pump. Okay, they're all there to kind of help keep that blood flowing. We talked about velocity of blood flow. Velocity of blood flow is inversely related to what? The total cross-sectional area, right? Again, the smaller the cross-sectional area is, the faster the velocity will be. The bigger the cross-sectional area is, the slower the velocity will be. And again, I always think of the stupid garden hose. You cover your finger over it, the water comes out faster, et cetera, et cetera. Control of blood pressure and blood flow. Again, this is due to the cardiovascular system that's located, cardiovascular center that's located in the medulla. that cardiovascular center controls not only the heart, but it also controls the diameter of all your blood vessels. There's a couple reflexes that are built in that you should be aware of. What's the name of the reflex that helps you maintain normal blood pressure in the brain? That's called the brain normal blood pressure reflex. No, it's called the carotid sinus reflex. That helps you keep normal pressures in your brain. What's the name of the reflex that helps keep normal pressures throughout the general body?
Aortic.
The aortic reflex, okay? Keep in mind that there are different types of receptors that send signals into the cardiovascular center. Baroreceptors, what do they monitor? Pressure. Chemoreceptors measure chemicals. So chemoreceptors measure things like oxygen levels in the blood, carbon dioxide levels in the blood, hydrogen ion levels in the blood. And then one more type of receptor are proprioceptors. They send signals in there as well. In addition to the cardiovascular center and the neurons controlling blood pressure, you also have hormones that play a role in regulating your blood pressure. We talked about a lot of hormones that increase blood pressure. So the renin-angiotensin-aldosterone system, that's going to increase blood pressure. Epinephrine and norepinephrine, that's going to increase blood pressure. Antidiuretic hormone is going to increase blood pressure. But what was the one that decreased blood pressure? ANP, atrial natriuretic peptide. It's kind of the oddball. All the other guys were devoted to increasing your blood pressure. That's the one that's devoted to decreasing your blood pressure. And where is ANP released? Heart. It's atrial natriuretic peptide. When the heart wall is stretched, it releases ANP. And what does ANP do to help you reduce your blood pressure?
Promotes the
Vasodilation.
loss of Na, sodium. and water.
Yep, both of those things. So first of all, it's a vasodilator. That's basically going to open up those arterioles and allow blood to kind of move out of the arteries and into the capillaries, etc. So that's going to reduce the blood pressure right there. And then also, it's going to cause you to pee out more sodium and water. That's in your urine. So that's going to decrease your blood volume, which in turn decreases your blood pressure. What's the name given for the ability of a tissue to kind of control its own blood flow?
Autoregulation.
Autoregulation. So it's a way to kind of override what the rest of the body's doing. I mentioned sphygmomanometer is the name of the device that measures it. What's the name of the sounds that you listen for when you're doing somebody's blood pressure? Karate cough sounds. I really got to look this person up. Did they ever do anything else in their life, or did they just rest on their laurels? Did they go on a big book tour and write all about how they came up with the names for these sounds? What did they do? Did they support themselves just on that one thing? It keeps me up at night. I worry about that. All right. So shock. Shock is when your cardiovascular system is failing you. It's not doing its job. It's not delivering oxygen, nutrients the way it should. What's the type of shock called where your heart's to blame? It's the heart's problem. That's cardiogenic shock. What's the problem? What's the shock called where it's due to some kind of a blockage? Obstructive shock. What's it called when maybe you had some blood loss and there's just not enough blood volume? Hypovolemic shock. And then when there's too much vasodilation, that's called vascular shock. Again, in the US, septic shock, which is due to overwhelming infections and bacteria getting into your blood, that leads to vascular shock, and it's the most common cause of death in hospital critical care units. Okay? So, yeah, just be aware of that. Some homeostatic responses to hypovolemic shock. You're going to turn on the RAS. You're going to release more ADH. You're going to turn on your sympathetic division. But then some organs might do autoregulation just to ensure that they get good blood flow. So they'll release local vasodilators just to make sure that they get good blood flow. Blood vessel routes, circulatory routes. Again, there's the pulmonary circulation that's powered by the right side of the heart. There's the systemic circulation that's powered by the left side of the heart. Make sure, again, you review those pictures of the different blood vessels, of the arteries and the veins, because there will be some questions about specific blood vessels that you'll have to answer. There won't be any pictures, but you should still be able to visualize things. For example, I don't know, what's the name of the first large artery that comes off of the ascending aorta? Brachiocephalic artery. Yeah. What's the name of the first arteries, period, that come off of the ascending aorta? The right and left coronary arteries, right? Okay. Make sure you know this stuff a little bit. Hepatic portal circulation, that's all about absorbing nutrients from your stomach and your small intestine, and then bringing those nutrients via the hepatic portal vein to the liver, where it gets a chance to kind of examine it and possibly detoxify what you've just eaten or what you just drank before it then sends it out into the general circulation. Fetal circulation, make sure you know those 5 special blood vessel things that you have in the fetus, and make sure you know what they change and do, what they're called in an adult. Blood pressure problems, hypertension, most common disorder affecting cardiovascular system. Make sure you look at that little table that I showed you. There'll be like one question from it. That's pretty much it.
Are we gonna
All
go
right.
off the new numbers you gave us or these numbers?
What's that?
You said this chart had changed? So we're
Go
going
off what's in the PowerPoint.
Okay.
Yeah, go off what's in the PowerPoint. All right, so now we are going